Assalamu alaikum, everyone. My name is Razan Elhassan. I'm a second year medical student. Inshallah, today I'll be explaining enzymes in clinical diagnosis, and I'll be pointing out the high yield stuff that you need to know for your exam. And I also cross-checked this with the recording, and I'll tell you what you need to know and what you don't need to know. In addition to that, please feel free to stop me at any point if you didn't get anything. And later on, if you have any question, please contact me either on WhatsApp or email. So these are the objectives, inshallah, I'm going to cover, and then we're going to end up with some practice questions, inshallah. So basically, for the intro, you have been introduced previously for enzymes that they increase the rate of reaction, and they are proteins. For now, keep this in mind, proteins. I'm going to let you know something later on when we carry up on the lecture. And specifically for this lecture, what's important to us that enzymes show tissue-specific expression. What does that mean? That means every tissue in our body has specific enzyme that indicates there is an issue with this specific organ. For instance, the liver has specific enzymes, bone, and so on and so forth. So if we want to alter the enzyme activity in our plasma, how would that occur? Or if it's altered, how would that occur? It's either inherited, there's mutation or something like that, and always or most likely there is a decrease in enzyme levels in the body when it's inherited. If it's acquired, it most probably would be elevated. So either we said it's less than normal, it's either due to less synthesis or it's due to inborn error of metabolism. And if it's higher than normal, it would be either cell damage, like trauma or something like that, or cell proliferation, which is basically a tumor or any cancer. So for the inborn errors of metabolism, we said that it's a mutation. This mutation would lead that we don't have a specific enzyme. So for instance, we have a substrate that needs to be converted to a specific product. So and if we don't have this enzyme, this substrate would accumulate. So this is what happens exactly in the inherited mutations. So if there is an inborn and we need to check the levels of enzymes, we cannot check them after birth directly. And why is that? Because the needs or the metabolites that the infant needs already this infant have them from the mother due to the exchange in utero. So we most probably do these tests 1 to 2 days after birth, or maximum by 3 days. So at that time we can know if there is deficiency or not. So if we found there is deficiency, how would we treat this? We would treat it either by dietary modifications, potential gene therapy, or direct plasma replacement. And these are some examples. Some of them you took them, I think, in MOL 1, and the others you will take them, inshallah, in MOL 2. They're not really important for this lecture, but inshallah, when you take them for their respective lectures, they would be high yield. Like, for instance, here, the urea cycle one would be later on high yield, carbamyl phosphate synthetase 1, and MCAD-D would be also important, and Lesch-Nyhan syndrome 2. And just familiarize yourself with them if you want to read them. But other than that, they're not important right now. And here we go for the plasma envelope. So normally, enzyme levels, that we have them, or basically the enzymes, mostly we have them inside the cells. But we have small amounts that we can find them outside the cell. So basically, these are either actively secreted enzymes or released during cell turnover. And this is basically in a healthy individual. So what are the actively secreted enzymes? We have enzymes that, for instance, from the liver, these enzymes, they are inactive when they are in the liver. But when they are released into the bloodstream, they would be activated, and we need them for the clotting factors or clotting cascade, basically. The other one, which is enzyme released during cell turnover. So what's that? That basically when we have the old cell and we need to replace it with a new cell. So basically the cell, the dead cell would release a little bit amount of enzyme into the blood capillary here. And this, when we measure the level of enzymes at this point, we wouldn't have them like abnormal levels. Why is that? Because this release of enzymes would be balanced by plasma clearance. So the levels would be normal. So no matter what happens, the levels would stay normal. So, but in the abnormal part, for instance, let's say we have a cell damage, either toxicity or cell death or hypoxia, the many cells are dead, so they start releasing abnormal levels of enzymes, which is not the normal thing. So when we measure at this point the enzyme levels, it would be elevated. So the higher the enzyme level, this indicates that we have a greater tissue damage. And if you want to measure an enzyme, this process is not invasive. It's just basically in the lab, just taking blood and it's over. And this helps us also in checking the prognosis of the disease, either if the disease is progressing well or it's going bad. And also we can check the treatment is working or it's not working. For the measurement of enzyme levels, we use also the international unit. What's basically the international unit? It's 1 micromole of a substrate that needs to be converted into a product per minute. So this is the international unit. You just need to know that this is what's the unit of the enzymes. It's international unit. So here's a concept we need to know it. What's the difference between the plasma and the serum? So plasma, you ask the patient to go to the lab and you withdraw blood or take blood, and at that time you add anticoagulant to the blood. When you add the anticoagulant to the blood is not going to clot. So you take this tube and you put it in the centrifuge, start spinning the centrifuge, and again take back the tube. So in the tube, you'll be having, or the tube will be looking like this. So we have the blood, which is like basically it's not clotted, the normal red blood cells. Here we have the buffy coat, or WBCs, and we have here the plasma. The plasma here includes the clotting factors, which we prevented them from making the red blood cells and white blood cells and these things to clot together. This is the plasma. And also note out that clotting factors are proteins. Again, here for the serum, you do the same thing in the lab, but you don't add an anticoagulant. You let everything just mix together and you take it to the centrifuge. When you centrifuge this tube, you're going to get this shape or this appearance of the tube. So here the blood clotted, like everything is here, the WBCs and platelets and red blood cells. And just here you have the serum. So serum, it's just the plasma minus the clotting factors. So for plasma, when we want to measure the enzyme levels, we don't use plasma. We use serum. So here I mentioned why is that? Why do we use serum instead of plasma? Because plasma, I mentioned that it has clotting factors, and these clotting factors are proteins, just like the enzymes, which are also proteins, and this could interfere with our measurement, and they couldn't be, or they wouldn't be accurate as much as we want them. So we use serum. Here we have also another concept, which are isoenzymes. What are isoenzymes? They are enzymes that catalyze the same reaction, but they differ in molecular structure. So this is the only most important thing you need to know about these isoenzymes, and we're going to talk more about them here. An example about the isoenzymes, the keratin kinase or keratin phosphokinase. So we have three isoenzymes of keratin phosphokinase. We have the CKBB or CK1, which basically is found in the brain and lung. CKMB, this is the important one, we're going to deal with it, which is predominantly found in the cardiac muscle. And also we use it for the myocardial infarction relapse. It's not the primary enzyme we're going to check. CKMM is keratin kinase 3, and we're going to find it in the skeletal muscle. And this is the equation that it catalyzed, but it's not really important. Phosphokeratin is just an energy reservoir. We use it for muscle contraction. You'll be taking it in MSK much more. But the most important thing for right now is this three isoenzymes. The most important, also one of them, is CKMB2. Another example is lactate dehydrogenase. We have the LDH, which is the abbreviation of lactate dehydrogenase. It's present in all tissues. So we cannot use it as a specific marker. So if we have hemolytic anemia, it's going to be elevated. Some types of cancers, it would be elevated. So how could we differentiate? Like, which organ is releasing this LDH. So it's classified into numbers like from 1 to 5. 5 is for liver and skeletal muscles. So how to remember 5 is for these, like liver is kind of big and skeletal muscle is big, so just give it the number 5. Then we have LD2 is for red blood cells. For LD1 is for heart. You have just one heart, so it's one, the two, just give it to the red blood cells. For this diagram, Dr. Raja, she said that it's not much important. You don't need to know it, but just I added for the sake of completion. So here you are doing electrophoresis and you're checking the migration of these isoenzymes. So you have here the LDH1, which is this peak, and here LDH2, 3, 4, and 5. So this is the normal one. When you look for an abnormal electrophoresis, and here you have this peak, which is the LDH1. So you know that LDH1 is for acute myocardial infarction. And here also the same thing. You want to look for the peak, and the peak here is for LDH5, and it's acute hepatitis. So how would we use enzymes in clinical applications? It's either we use them for diagnosing or for therapy, or we use them in lab. The first important part of this lecture, Yani, you have the enzyme profile for myocardial infarction. So you have three enzymes, or actually this is the enzyme, and these, like this is a protein enzyme, and this is a protein, and this is also protein, but they're non-enzyme. So we'll start first by knowing what is the ideal cardiac marker. All of this is important, so I just highlighted here the title. So you need it to be released by an injury. It's not just always high, and also it should be specific for a cardiac muscle, and it should be elevated for a shorter duration, for not for a long time, and you can easily measure that enzyme. So what are the cardiac biomarkers that we're going to measure? We have troponin and CK and B. So the important one and the golden enzyme for cardiac biomarker is the troponin. You do troponin, first one, because it's elevated for 10 days, which will help you know that this is myocardial infarction. And again, here troponin is a protein but non-enzyme, and also alongside myoglobulin. Again, here they are troponins. You don't need much to know about like if it's bound by what bind what, but I added for the sake of completion. You need just to know that the important troponins that we need them for myocardial infarction is troponin I and troponin T. They're most specific for myocardial infarction. So why do we use troponin? Because it's most specific and sensitive, and it's elevated for 10 days. But for instance, if we have reinfarction during these 10 days, we cannot measure again troponin. Why? Because still, we can't differentiate if it's if it's a reinfarction or not. So we just go for CKMB, because CKMB in the first reinfarction, it was just elevated for 2 days. So we can just remeasure the CKMB, and it would tell us if there is a repeated heart attack or the myocardial infarction. So these are the two important things you need to know them for the myocardial infarction. Then for the liver, we have 4 enzymes: ALT, AST, ALP, and gamma GT. Specifically for liver, we prefer the ALT instead of AST, because AST could be also elevated in myocardial infarction. So this could not be very specific for liver damage. So you could get a scenario that says there is a patient who's 68-year-old and has got either, for instance, in the question, it says maybe a fatty liver disease or viral hepatitis, and it would ask you if we want to measure, we measured the enzyme levels in the blood, which one would be elevated. So in this case, this would be, the elevated enzyme should be ALT in this case, because they said fatty liver disease or, for instance, viral hepatitis. But if they told you a man who's like 50 years old, who's alcoholic, or they told you that there is a liver cirrhosis due to his alcohol habits, we measured the enzyme levels, what would be the elevated enzyme at this point. It would be the AST. So you need to know when is ALT elevated, at which liver damage status, and when is AST elevated. Then also you have the ALP. The ALP would be elevated in two cases. If you have a bile duct blockage, or which is the cholestasis, and also inborn disease. So if you want to differentiate between ALP when it's elevated in the bile duct blockage or the bone disease, you need to measure gamma GT. So if you measured this one and it's elevated, now we want to double check. We're going to measure gamma GT. If gamma GT is elevated, this is definitely bile duct blockage, and you just rule out the bone disease. If was normal, then it's bone disease. If the gamma GT is normal, then it's most probably bone disease. Again, yeah, for ALP, if you have bone disease, it could be rickets, osteomalacia, or Paget disease. Then here we have the salivary disease and the pancreatic disease. For the salivary disease, it's always the alpha amylase which is elevated. But you want to rule out pancreatic disease because also we have the alpha amylase is also elevated in acute pancreatitis. So what would you do? You would differentiate that by lipase. If you found that lipase is elevated, it's then definitely pancreatic disease. If lipase is normal, then it's a salivary disease. Then here we're done with the enzyme profile, like the diagnosis. Now we're going to the therapeutic enzymes. This part is not important. I don't remember we got a question about this, but just know it just in case just in case you got a question about it. So how do you treat by giving enzymes? So you give streptokinase or urokinase or tissue plasminogen activator in case of someone who has myocardial infarction or deep venous or vein thrombosis. Also, you can give asparaginase, which can treat leukemia, or you can give trypsin lipase in the case of pancreatic insufficiency. Then finally here, you can use them as a laboratory agents, like in DNA analysis techniques, and you took that in molecular techniques, the restriction endonuclease, DNA polymerase, DNA ligase, and then you have the ELISA. This part also is not much important. The much important enzyme is the diagnosing part. And the ELISA here, you have the enzyme, the antibody. This antibody would capture an antigen. So you cannot know if this antigen is related to this antibody is related to this antigen unless there is another antibody that has a fluorescence or detection antibody that binds also to this antigen. When you have fluorescence or you have light, means this antigen bound to this antibody, and it's both are related to each other. Finally, here is a summary. You can just go over this table as a quick summary for you. Here we have the 5-alpha nucleotidase. I remember we got this lecture from Dr. Hannah last year, and she told us in case you found this in the MCQs, don't appeal it. So just know it. She said that it won't be an answer for a question, but just know it, just in case. We are done, and here are the questions. I think no one is here. I can just go over the questions, and later on, when you watch the recording, if you have any questions regarding these questions or the lecture, feel free to text me. So here in this question, they are telling us that this is a 57-year-old man. You're going to just look out for the keywords here in this question. So he returned from an overseas trip and reports he had substernal chest pain. So this is your keyword here, the substernal chest pain. Which of the following the most appropriate laboratory test to order for this patient? So since this patient has chest pain, this indicates that this patient has myocardial infarction, And myocardial infarction, the most appropriate one is the troponin. It's not keratin kinase. We said we do that for reinfarction. It's not lactate dehydrogenase. It's not very specific. And it's not aspartate aminotransferase. This is for liver. And also it could be also elevated in myocardial infarction. So it's not that much accurate. Then here we have a male who is suspected of having experienced massive lysis of his erythrocytes. Positive results for which of the following tests may help confirm his suspicion? So we mentioned that the hemolytic anemia we could have, which elevation of which enzyme, sorry, it would be the LDH. So looking at these, we didn't talk about this one, either this one or this one. So it's basically the LDH in blood serum. So, and here, this is another question. Which biomarker is most commonly used for diagnosis of pancreatitis? So we have lipase or alpha amylase, ALP and troponin. So you can look for this and this, but don't confuse it. We said the lipase is the one we differentiate between pancreatitis and salivary gland disease. So it's lipase. Last one, which enzyme is most specific to the liver diseases? It's AST. Oh, wait. No, sorry, ALT, yeah. ALT is the most specific for liver diseases. AST is elevated also in myocardial infarction, so we don't use it much unless in the question they specified that this person is alcoholic or something like that, then AST would be the answer. Here we came to an end. If you have, as I mentioned, any question later, let me know, and please scan this QR code and give me your feedback for further improvement. Thank you.